Hello, everybody. Thank you so much for joining us at this HITLAB Summit 2021. We're joined by a wonderful panel of folks based out of Uganda to talk about health equity and how their app, Mobi Clinic, is transforming the way people access healthcare out in that part of the world, out in East Africa. So thank you so much for joining, you guys. I would love if you start off by a round of introductions, and then we'll jump right into the panel discussion.
All right, thank you, Julia. I'm very glad to be here this morning, and I'm sure everyone is glad to be on here. My name is Andrew Dembe, and I'm a lawyer. I'm also the founder and chief executive officer of Mobi Clinic. And Mobi Clinic is an organization that is revolutionizing and easing health delivery in rural and low-income communities of Uganda, but also having a vision of easing healthcare delivery in the interruption. Sorry for the interruption. But as I was saying earlier on, that Mobi Clinic has a vision to ease healthcare in rural and low-income communities of the developing world, because half of the people in the world lack access to basic health services, and these usually come from the developing world. We are talking about 3.8 billion people. So we are not doing enough, and we need to do more, and this is where Mobi Clinic comes in with a better model that ensures health equity. I leave the floor to the rest of the panelists.
Thank you, Andrew. Great to have you on.
Hello, everybody. My name is Sumaya Ali. I'm a researcher and co-founder of Hello Afi. Was introduced to Mobi Clinic by Paul, one of my colleagues. And on learning about Mobi Clinic's work and seeing how Mobi Clinic's vision is in line with mine, I got excited and jumped from the board to the opportunity to be an advisor. So I'm one of the members of advisory board now with Mobi Clinic, advising them for over 11 months. Seeing Mobi Clinic's journey and progression, it's been amazing to be involved in seeing the progress and improvement and how they use technology and they use innovation to find local solutions in Uganda. Over to you, Julia.
Hello, my name is Alim. I'm a public health specialist and an M&E consultant, teaching at Clark International University, where I also coordinate community engagement activities. I'm very passionate about community activities because I believe that when people know their own problems, they can be able to actually solve their own issues other than wait for bigger organizations, government, to come and do that. So I got to know Mobi Clinic through those kinds of engagements from Dembe. Dembe approached us and we had to go over to do a medical camp in Buiko district. And I was very amazed of how such a community can be well organized and they are using their own resources to be able to meet their healthcare needs. And us as a university, as an institution, training healthcare professionals, the only way that we can be able to support such communities is to extend people that can provide services. These are the healthcare professionals. We can also see how to engage them in training so that they provide skilled, they be able to provide services, So yeah, and I'm happy to be serving on the advisory board of Mobi Clinic. Sure, and I hope to work with them anytime they call me. Thank you.
Thank you, Alima. And Paul, over to you.
Thanks. I am the glue that Andrew used to bring Sumaya, Alima, and another 16 people together as his advisory and oversight board. So I act between the board and the advisory board. after being introduced to Andrew when Mobi Clinic became one of the final 100 out of 176,000 entries to the EWC Entrepreneurial World Cup last year. And Andrew saw a little bit of benefit in having me in the back room supporting him. So I've been with the Mobi Clinic team for the last 18 months.
Just an extraordinary panel of people here with us today. Thank you so much for introducing yourselves. Why don't you give us a short overview of what Mobi Clinic is and how it actually works, what it does?
Right. Thanks, Julia. Now, we shall start from the global perspective. We have half of the world lacking access to basic health services. And this is according to a report by the World Economic Forum, Global Risks Report 2019. And it notes that half of the world, that's 3.8 billion people, lack access to basic health services, despite the fact that billions of dollars are injected into global healthcare annually. So people in the developing world, especially the rural and low-income communities, are still struggling with accessing basic health services. And this is a reality for some of us also who come from these areas. And that was the foundation. It was the motivation of what can be done to use the available resources without complaining about what we don't have. But how do we use the few doctors we have and work out a model that ensures decentralized and democratized services. And so at Mobi Clinic, we recognize that number one, in Uganda, we have few doctors, generally few health workers. So the first thing we do is to work towards empowering community health systems that let more people partake in their own healthcare in the communities. Let us work with trainers to train more volunteers who are known as community health workers within the communities, such that anyone who is facing a disease or an ailment, they do not have to get worried about moving many kilometers to the near health center. You should note that the government framework, just like many governments in the developing world, for every 200,000 people, that's when they build a health center. The doctor to patient ratio in urban areas here in Uganda is 1 to 9,300, but in the rural areas it's 1 to 40,000. So we clearly have a problem. And what do we do at Mobi Clinic? Number one, empower the community health system, train more community health workers. And now we go on to realize that these people's training is limited. So what do we do after that? We create a backup, which we call a digital safety net, which is simply an application that enables interface between community health workers and the senior medics. And our theory of change is leveraging this digital safety net to ease health delivery in these target areas. We do believe that when you create an interface between the community health workers and the senior medics, there is a lot of communication and a lot of easing of service delivery that will happen, and that's the first step. Now the app goes on to enable emergency responses, but also to enable referrals, integrated referrals. So when we go in an area, we onboard all the players in the health industry in that area. We are very collaborative, and we simply supplement their efforts to ease their own service delivery. And we do this through digital solutions. So beyond the app, we are currently building an e-learning platform that is going to train more community health providers. So we believe when we do this, at the end of the day, and our model is rolled out, these that are struggling with health access, no one is going to be able to complain about health access because we have used the resources on table to see what we can do with the little resources and maximize productivity. So that's it in a nutshell about Mobi Clinic. Okay.
Fantastic. And I really think that there is something to be said about, maximizing resources that you already have. It's a very common sense approach, I think, that sometimes is somehow overlooked. So it's great to hear that that's the core of Mobi Clinic and how you guys work. And you touched on this a little bit, Andrew, already, about how the healthcare system in sub-Saharan Africa, parts of East Africa, they're typically ill-equipped and understaffed. So this makes access for rural communities very difficult. I know you mentioned, the doctor-patient ratio is 1 to 40,000. So what are some of the innovative solutions that you are aware of that are being adopted to reach these last mile communities, more broadly speaking than Mobi Clinic specifically, perhaps?
All right. Currently, most of the technological innovations in the health space are still having an issue that they are still focused on the urban populations, and these are why we are having that reality. It's because of the socioeconomic factors. The urban populations can afford also the innovations and the innovators' work, and still there are very, very few players that are exploring, that are going in the space of last mile communities. I think many people get discouraged because of the smartphone penetration, but for us on our side, we are motivated by the fact that actually smartphone penetration is on the rise, and even in these areas, people are picking up on smartphones. So there still needs to be a lot of effort in encouraging innovation in the space of last mile, because it's still struggling. And I must say, besides Mobi Clinic here in Uganda, I know another organization, Living Goods, which gives community health workers Android tablets to store data of what work they have done in the field and what diseases they have encountered, and this data is later picked up and it informs research and policies. So that's the only one that I also know within the last mile. But I must say, whereas there are hundreds in the space of urban areas, because everybody is focusing on the urban areas, there are very few that are taking the bold step of innovating for last mile areas. So there still needs to be a lot of effort, because that's where the bulk of the population is. In Uganda, almost 80% of the population lives in rural and low-income communities. So we must innovate for these people to also be able to access healthcare. Yeah, so that's it, Julia. I'll leave it to the rest of the panelists.
It's interesting, Julia, picking up on Andrew's points. We're seeing some knee-jerk reactions from Europe in terms of migration, but migration is the big driver that Andrew has picked up on, and Halima and Sumaya will add to this. Migration starts from the rural into the urban, and we're seeing a deterioration in well-being of populations as they move into poor urban settings, where we're seeing recurrence of the basic diseases and illnesses occur again. We're also seeing continued, and this word is used regularly, traditional approaches, which are often planted by global organizations who say this is the way that we have to develop in a linear fashion, whereby what Andrew and the Mobi Clinic team are doing are taking quantum leaps. And Sumaya and I worked on Somalia, where we've seen the telecoms industry say, hang on, we've got the means to deliver not just a product to allow people to talk, but the means to deliver ways of giving people the capability to build on their innate intelligence and ability to learn. And so instead of implanting an international organization, we have the capability to build up on the possibility, the potential of people in the rural communities, reinforce community, and allow them to take control of basic service delivery and move us from a curative response into a promotive health system.
No, that's fantastic. And I really think that empowering communities in that way to be sort of self-sufficient in their own right, can go a really long way to having like a whole bunch of different positive outcomes across the board. I think one thing to add to that too is in many sort of developing countries, there's a high cost of healthcare. There's a lack of affordable insurance schemes, and it means a lot of people don't receive the care they need. And so I was wondering how your local solution works to make healthcare affordable as well as accessible for this 80% population you mentioned, Andrew, that lives in rural areas in Uganda. So,
Yeah. All right. I'm going to let that over to the advisors who are also in here. Yeah, please haven't yet said a word.
All right. I can look at first, before we look at strategies and what is being done, we need to know why we have failed these rural communities. So you find that these communities have failed to attract skilled personnel to go over because of probably the low wages, the poor working conditions. So what happens is that because these highly specialized and trained individuals are not attracted to go to work in the rural community because of the thing that I have mentioned, and yet we all know that human resources for health is one of those part of the 6 blocks, building blocks of a health system. So communities have got to organize themselves. And what I like about Mobi Clinic is the way they have organized and identified persons that they can actually train to be able to reach out to these individuals and then let them know where they can actually find services. So if you're not having an expert come to your community to serve, but you can probably train. So there is what we call the village health teams. So Mobi Clinic trains, identifies persons with capabilities of identifying the needs of these persons in the community per every household, and then the members actually are able to organize themselves and report to these persons who can actually advise them how next they can be able to access these services. Otherwise, if we are waiting for somebody to train and send these experts, people are going to die in their houses. So for me, I think that the initiative that Mobi Clinic is doing to engage communities to participate in their own health is a very good one, because when communities know that if we go to house number 4, there is a community health worker, or what we call a healthcare professional, who has been trained, because Mobi Clinic is training them, so who has been trained, and at least he knows where these guys can get a minimum healthcare package for the community. So that is one strategy I can talk about. Someone else can probably add on that.
I'll jump on that. I mean, Alima is very right. She touched on a very important aspect or principle of Mobi Clinic, is to empower the community and train them to be aware, empowered with knowledge, to be able to help the first initial contact of anybody on the ground. When discussing with Andrew, there is also an element of already like knowledge transfer. Community health workers are definitely limited, and where they've experienced something they're not aware of and they're not so sure of, there's always somebody they're able to contact with. There's always they can key in on the app. They can always call in to somebody who's a healthcare professional, more experienced, to get feedback on what treatment, what to do, or either to treat there or refer to a close by health facility. They even go as far as one time Mobi Clinic had a motorbike and actually physically take people to the nearest health clinic. What I like is the intersection or the linkage between physical and digital, where it meets in the most remote areas, in the last mile villages, where everybody is not there, and Mobi Clinic is there. And that's what makes Mobi Clinic very unique. Everybody is very comfortable in the urban setting and providing healthcare and digital solution where the smartphones are available and people have all able and are capable to be able to receive this very easily. But in the last mile village, you have to think of innovative ways. You have to be a problem solver, and you have to really look at ways to be able to really, save lives, basically. So as Mobi Clinic grew and experienced, the community health workers now learn and less need to consult on some of the basic things to help save lives. You see, so I like the transfer of knowledge, and this leads to hopefully providing some learning platform for them to make their skills more official.
No, that's great. And I know, Alima, you mentioned that you guys at Mobi Clinic will go and identify people that you think would be good to be sort of these community health workers. I was wondering how you go about that decision process. Like, what does it take? What does it take for somebody to be a good healthcare practitioner in the community with Mobi Clinic?
All right. To take on your question, Julia, first of all, it's twofold. Number one, any person, the ministry recognizes that at the base of the pyramid of service provision, any person willing to be trained as a volunteer in the first line response of healthcare can be trained, and they become the part of the village health team, or what we are calling the community health worker. So yes, the first is the willpower and the interest of the individual willing to be trained as a volunteer, aka also known as the community health worker. That's the first one. Second one, in areas where some of these people were trained by government and have taken long, because this is a reality. When you reach there, you find that in some areas, government had taken initiative to train these people, but they have been dumped for long. They are ill-equipped, and then I must say, even their knowledge must be refreshed, because you find that they were last trained 20 years ago. These are not people now you're going to entrust with treating the basic ailments, because sometimes they are forgotten. 2 decades they are forgotten. They simply have the title when you go to the community, but the skill set must be polished and refreshed. And this is where we partner with trainers, and most recently we have partnered with Clark International on the e-learning platform that we are coming up with. Yeah, maybe Madame Alima is also well versed with community health. She can also jump in to elaborate on this.
Please do go for it, Alima, if you have something to add.
So in Uganda, there is a VHT framework for training, and it's available at Ministry of Health. And that is what we use to be able to identify this person, to train. So what happens, like what Jembe says, because I think he comes from that community, and then he knows that community so well. And he mentioned the willingness of persons, so if you're willing and you're a member of that community, then there is this framework for training VHTs, and then there is a whole package of what a village health trainee must actually know. And we use those manuals to develop the curriculum for the training. So currently, Clark International University is actually working on videos. We have been studying the training manuals by Ministry of Health, and then we are coming up with content that is specific to that region. So yeah, that is the training manual that we are using. And of course, before they actually start to practice, they have to be trained, and then they shall actually be given certificates to show that they have been trained, and then they can also become trainees, and they be able to train others, so that we just keep on transferring that knowledge. So yeah, there is a guide to training there.
And I think it's important to also realize Mobi Clinic and others, contemporaries of Mobi Clinic, are looking to have an impact. They are looking at outputs. what we have continued to see in recent years is input-driven aid and development. And so we often see the development of curricula without the knowledge of what skills have been transferred. And Alima is being slightly self-effacing because Clark University site have set up to ensure, and Andrew has brought in Sumaya and Alima, not just because of their health interests, but because of their learning and evaluation skills. So what we're now seeing is not saying we run a training course for 150 health workers. What we're doing is seeing a change that we are now impacting on promotive and preventive health to deliver healthcare systems, particularly to women and those first 1,000 days of childhood. And we've seen a diminution of the different illnesses and diseases that are hitting people. And through that, to go back to one of your earlier points, Julia, we're seeing people say, hey, I can do this, we can do this. And so it's changing the dynamics of community development on a much broader picture built on people's well-being.
Mm-hmm. Mm-hmm. Amazing. And actually, to your point there, Paul, I wanted to ask, because obviously, you know, an organization like Moby Clinic cannot exist in a vacuum, right? There's an ecosystem around this, and so I was kind of wanting to tap into that and ask, what's the role of partnerships in your work in overcoming these challenges of getting healthcare access to the folks that need it most out in these rural areas? Do you guys lean on partnerships at all with your work in Moby Clinic?
Alima Alima's boss, the founder of Clark University, Dr. Clark, is actually also part of what Andrew's been innovative in thinking about. So the partnerships are there. What is changing is the nature of partnership. And again, Alima, I'll hand over to Alima. We've noted government and government's frustrations in not being able to deliver to people. And it's true across everywhere where we work in East Africa. It's a frustration. It's not a failure of government, it's a frustration of government. And we're seeing the dynamics of what is aid and development and the industry that is aid and development. So over to Andrew. Sumaya also has tremendous experience in just how we are changing the nature of partnership as an integral development agency rather than just a service provider.
Yeah.
And also to jump in just at this moment, yeah, partnerships at the end of the day is the work, because the magnitude of the problem requires all stakeholders to be part of the efforts. You know, we believe in supplementing each other's efforts and working together. But the reality on ground is that for a young organization like Moby Clinic, we usually find audience and the will for partnership in the non-government actors, for instance, the private university, Clark International University, and other people. So you find that obviously we shall be binded by the like-mindedness of different actors, and you know, those who share the passion and will, we shall work together. And so we don't have to be discouraged by the partners who we aspire to but are not willing yet to be on table. And for us, we keep pushing, and we are joined by the like-mindedness, like I did say, and the shared vision. So that's it as regards partnerships from my end. I think Alima also has something to add then to my end.
To add on to what Andrew said, in terms of giving services or providing services, the community itself is the biggest partner that you can ever have, because you can't just come and impose innovations to people that you have not involved in programming, in doing everything, because they will not utilize those services that you're bringing forward. So the fact that Mobi Clinic is involving communities, that is the greatest partner they are having. And then they are tapping onto what we call the think tanks, the think tanks. These are universities, So now that Clark International University is on board, I hope Mobi Clinic can also identify another institution, because with the universities, they do a lot of research, they do policy analysis, and for me, I think that they are supposed to be at the forefront of any health agenda, because they are able to go down and dig and find out the community needs, the health needs of the community, because most often we provide services probably that are not seen as required by the community. So if we can have these persons that are able to go there and do research and analyze, and then there's something that I thought about, that even when we train these personnel and they get the experience, they have the skills, and then they are adequate in number, without governance and leadership, nothing is actually going to happen. So all in all, we still need our government. We need to be able to partner with them for them to be able to train, the hospital administrators. They don't only need the medical skills, but they need human resource management skills. They need health service management skills. They need hospital management to be able, if I take on the recent crisis that happened in Uganda, when nurses are putting their tools down, you notice that some of these things could have been just avoided by good leadership, So we also need those leaders that can be able to probably advocate for public health policies, because when you look at the communicable diseases that we are having in our country, they are those that can actually be solved by good public health policies, So yeah, having said all those things, the partners and what, we still need the government to be one of our biggest partner here, and then they need to actually pass those policies that are pro-health, and then we need also those guys who can sit and then also talk about the budget, the healthcare budget, because when you look at the community health workers, they are not really paid that, and yet they are at the they are the first contact of the individuals. They connect the individuals to the entire healthcare system. So the NGOs, they are very good, and I think the private and the not-for-profit, like Uganda Protestant Medical Bureau, there's a Catholic Medical Bureau, and I think Mobi Clinic has worked with Uganda Protestant Medical Bureau in one of their medical camps, and those private and not-for-profit organizations, they serve almost over 80% of the population with those services, and they are really affordable. So yeah, those are the partners that we need, and not forgetting our philanthropists, Yeah.
Yeah, and I'd actually like to touch on something that was mentioned earlier about how it's not a failure of government, it's a frustration of government. So just to that point, before we move in a slightly different direction, I wanted to ask sort of if you have any feedback from the government and how they are involved in this, or how you would like them to be involved in this. Like how has the government in Uganda reacted to Mobi Clinic, for example?
Thank you for the question, Julia. We've initiated talks with the local authorities and in the community where we are in the district in Buikwe. It was finally well received, but after a long process of bureaucracy and so we've also tried efforts with the ministry, and I must say this is continuous, because with innovations, they're disruptive in nature. So they're disruptive in nature, and you must bring the regulators on board to understand what the innovation is all about. But quite also, unfortunately, on another hand, is that the willingness of these people sometimes is discouraging to the local innovators, because you only begin to capture their audience when you have done much of the work on your own, when you have attracted the partners that always impress them, and that's when they will give you audience. So we are also moving that journey because we realize that is how they operate, and which is totally not our fault. Yeah.
Just to add on to what Andrew said, I'll touch on a bit of partnership with the private sector partnership with telecommunications, providing a solid partnership where we can be able to contact, and there are a lot of examples across East Africa and Horn of Africa where telecommunication and internet providers are partnering with several organizations, especially Mobiclinic, to be able to reach out. So there's an element of public-private partnership, but also private sector plays a role and telecommunication plays a role. The mobile penetration in Africa is very wide, and the usage of mobile and internet is growing each year significantly for organizations like Mobiclinic to leverage on the technology to be able to reach people in the last mile village. So that's a very important point. Also, I think the role of the government, I mean, the government is there to anchor some of this initiative that's been provided. There's still lack of infrastructure in the rural areas, there's lack of connectivity between urban and rural linkages, to provide linkages. There's still that lacking, and there's lack of private-public partnership to be able to make some of these costs, high healthcare costs, more affordable, and in a package or schemes to be able to make it affordable for the low-income houses in the rural areas. I think, as Alima mentioned, leadership and governance, that we need that. And without that, lead and govern a lot of things, a lot of the efforts that local organization like Mobiclinic is doing will be hindered if there's no governance leadership to be able to expand these things. Of course, there has to be digital and health policies, legislation, regulation, and implementation of those things to protect some of these innovative solutions that have come up, and to be able to, be able to help them grow and expand and amplify some of the impact they're doing on the ground. Definitely the government is needed. There's a role for the government, and good governance, leave alone governance, good governance is needed. Over to you.
All right, to add what Sumaya has said, I will actually talk about the challenges that are in these areas when you come to innovate in healthcare. Usually what players struggle with in this space, especially in the rural areas, are two main things. Number one, that the communities are in terms of settlement, people are widespread out, in these rural areas. And then number two, there is low purchasing power of the services and what. So we recognized those problems, and why we say Mobiclinic uses a fusion of digital and physical means, it's because we bring together a fusion, which is one solution, but it solves the entire cocktail of problems that are underlying. It's because we research the depth of the problem. So how we overcome these two main challenges is simply through technology. Okay, so we use technology to mitigate and overcome these challenges, and that's why we are an ideal partner to government, because government should be coming on board with us to show them how we can, we can overcome this and how we are overcoming it. And so the use of technology enables us to beat the two main problems: the low purchasing power and the communities being widespread out. And you realize that by doing this, we simply create the frontline workers in the communities who are backed with our digital solution. And still with them, people in these communities are able to receive timely consults from senior consultants, without those consultants incurring costs of establishing hospitals, health centers in these areas. So we do believe, and indeed we are a more cost-effective solution. We believe to development agencies, we offer more development per dollar because still here in Uganda, we receive over $350 million in terms of aid every year for healthcare. So you can imagine, but still we have a big part of almost 80% of the population still struggling with access to healthcare. So we believe we offer a model that can be much, much cheaper than whatever is being used on healthcare, yet everyone can realize access to health services. So that's it. Just to add on what Alima had said. Yeah.
And Paul, I believe that you earlier had something that you wanted to add.
Well, Andrew's concisely put a critical set of points together, that we're actually looking at something, and it goes back to the big picture as well, Julia, and Alima and Sumaya alluded to it. Government must offer that umbrella under which all the different actors sit. We've just seen, you're sitting in Scotland. We've just seen COP26, which some people say is a cop-out rather than a cop-in. Climate change is impacting people across East Africa very dramatically. Sumaya just said it's continuing to rain in Nairobi at the moment, which is rather unseasonable. We're seeing massive extremes appear. So northern Uganda, southern Sudan, northern Kenya into Somalia have been dry. This is exacerbating health issues, well-being issues. And so we're seeing the need to fit the big picture down to the practical ways of delivering solutions. And then you will hear again people saying, let's do localization. Moby Clinic is an example of holistic localization, of giving people the skills and the capability to build on that innate talents to be able to deliver. Then you're also seeing about climate change. Government will sign the agreements, and then it must be for communities to be able to deliver for themselves. So each time we see a global agreement, its implementation, as Alima pointed out, requires us to bring together the different actors. And Moby Clinic has brought together public and private and made it the driver of the people who actually use and can deliver those services. We will not see tarmac roads to every village. It's not going to happen. We need to look, and it won't be drones all the time. It must be this blended solution. And it must be that people have a cost-effective means to deliver basic services for themselves, and then actually build that they can pay for those services within their own income sources. So we change the dynamic of basic service delivery.
Amazing. And actually, to that point, Paul, I want to put it to the panel. I know we're coming up on time, but just to sort of round out the conversation, I think it would be great if you could share some of the impact that Moby Clinic has had in the communities that they serve. Like, what kind of improvements have you seen? What sort of beneficial results have come out of the work that you've done so far?
All right, thank you. I'll just pick out two main programs. From January this year to September, we had a maternal health program that was supported by the US Embassy, Kampala. And in this program, we got more than 350 pregnant women who were facilitated on the program, who actually even gave birth through the program. And and in this program, Moby Clinic worked right from bottom to up. I mean, from the community health worker, from the health centers in the given areas, because all this is an ecosystem. We work together, and so we saw 350 women, over 350, getting impacted in that particular program. And then from January to April, we were supported by an organization, Sayana Press, and Sayana Press is simply a self-injectable to communities, to women. It's for family planning. Now, you must realize, Julia, that when you deny people the right to health, okay, it's the same. You've denied also the right to life, by the way. But let's just look at the right to health. When you deny the right to health, you have locked up all other forms of healthcare, including even the sexual reproductive health. So these communities still, they cannot access family planning options. And here we are, government and the stakeholders keep complaining about the rising populations. But much of the rising population is coming from these areas, You find a girl starts to give birth from the age of 14, onwards, and by the time at the end of the day, when she's done, she has about 14 children. You find people having 10 children in these areas. But this wouldn't be the case if at all you have community health workers who are doing a great deal on sensitization of communities on what to do with family planning, who do not just stop with sensitization, but avail the various options of family planning. And this is what we did. And over 1,500 women got the Cyana Press injections over the 4 months. And in fact, this is part of the programs we want to be continuing, because we saw that the result was overwhelming, and these are needed. So there is a great thirst in the communities. Over the past 2.5 years where we've of our existence, we've impacted close to 8,000 people with services. And so we do believe that our services are very needed, and that's why at this moment, much of our strategy is about scaling and taking the services to other communities that yearn for the services. So that's what I can respond as regards impact. Yeah.
Maybe to add on what Andrew just mentioned, when I look at the African context, I'm trying to bring it in terms of the services that Mobi Clinic offers, especially maternal and child health care services. Recently, we actually conducted a study where we found that we were looking at determinants of cesarean section delivery in the rural areas, and then we found that the prevalence of cesarean section delivery was actually high among the rural women. And what was more interesting is that these women, they continuously produce, because having many children is more of like a survival strategy in a marriage, because if somebody doesn't produce, then someone else will be producing. So they frequently produce, there is no spacing. And then according to obstetric information, it's that the more you actually produce, the more you are actually at risk of cesarean section. So that's why they were actually more at risk of delivering by cesarean section. And then I remembered that the first time we went to Buikwe district, we were actually providing health education. So health education, mothers need to know, your life, your health is more paramount and important than your stay in that marriage. So Mobi Clinic is doing a good job in sensitizing communities, and they've done that especially in terms of family planning. There's family planning available in the area, and then there's also information on where to practically find those services and how to use them, and that is very excellent. And that's why I always say that when you partner and then you get information and you use that information, then you're able to actually deliver credible services. Because in Uganda, we have a very good health management information system. We have a lot of data that we collect, but then we don't use it. So the fact that we are able to go out there in those communities and then do those studies and find out where the problem is, then we know specifically where to target. And Mobi Clinic has done that so well. I want to actually go and visit that community and then see how women are progressing in terms of reproductive health issues. Thank you.
Thank you, Halima. And I think that brings up a really good point too, of how social and cultural factors actually determine in great ways how populations or sections of populations interact with healthcare systems, and that it just goes to show that there is no one size fits all solution. And so, like I mentioned, we're coming up on time. So I know that this conversation could go on for ages, and it's wonderful speaking with you all and just having these really great back and forths. But unfortunately, we're going to have to wrap it up. So I would love to leave it to the floor for any closing remarks that you want to briefly make before we finish up.
Just picking up on what you just said, Julia, and building on Andrew's and Halima's points, culture is often a cop-out, again, to use that term once more. Culture is learned behavior. And for women in rural areas, as Halima is saying, with data and the capability to analyze data, women are able to stand up for their own rights because they're challenging what men are insisting is culture, which is actually wrong behavior. So the impact of digitization of healthcare has a far-reaching effect. To echo again what Andrew's saying, a small in opens up a real holistic solution for people.
Maybe I can jump in. Just to like closing remarks. I mean, I want to give homage to Andrew's work. You know, without his leadership and passion, a lot of us wouldn't be here today giving our time for the webinar, or people on the ground. I was speaking to him yesterday, and I was like, how did you did Mobi Clinic, how did cope with all the coronavirus pandemic, the lockdown, the elections in Uganda, there's insecurity. There's a lot of things going on the ground, but Mobi Clinic continuously continued giving work, providing impact. Andrew just told us what he did from January till the height of Corona till now, that they're still operating. You know, the thing that's fascinating is the volunteers, the people who started Mobi Clinic, who volunteered, the people who are still there working. I mean, the money is important, as Andrew was telling me. Like, money is important. It's true. It fuels the work they're doing, and it enables, facilitates the work to keep going. But I really like how that's not the first motivation of the people you speak. Anybody connected to Mobi Clinic, that's not the motivation. It's to create an impact which is lasting, and having funding and investment only provides an enabling environment to be able to continue that and make it sustainable. So I'm hoping that could be what Mobi Clinic future would be, hopefully.
Great. And to add on what she's saying, yes, Mobi is doing all these things. And my last remarks is that we need the stakeholders, we need government, but we also need the development agencies, because we believe we have a model that enables the SDG 3, the health and well-being. And so I know HITLAB Summit gets a lot of people across the world who are part of this summit. So we are very open conversations that help us to what can I call it? The ideation process on how we can extend elsewhere, but also on how we can give healthcare to more people across the world, because more people need this health. Like I mentioned, 3.8 billion people are not lucky like me and you. Imagine when you're sick, but you have to wait for a response in healthcare for a number of days. So there are people who are living that reality, who we need to join efforts and change their livelihoods when it comes to health. So on behalf of Mobi Clinic, we are very interested in meeting up who are ready to partner and also support who are coming from HITLAB. So thank you. I think Alima will close up.
Yeah, so my closing remarks, I'll start by saying, this COVID-19 pandemic really exposed the weaknesses in the healthcare system, ranging from inadequate human resources for health, limited resources, and then also no vaccines, no supplies, and all that. So what I like about Mobi Clinic is that doesn't deter their activities, So whether they have resources or no resources, they are using the available hanging fruit, the community itself, to be able to reach out to communities. And I think that every individual needs to know that first, it is your health, and you need to take care of your health. So as where governments and organizations are failing, we can collectively put ourselves together as small communities. We look at what we have that is available as we look forward to different bigger things that are actually coming along. Public-private partnerships for health are very important. We need all the international organizations, the development agencies to come up and then support, but let them find us doing something already, and then they can be able to join in. So thank you, Mobi Clinic, for all the initiatives that you're doing, and Clark International University is willing to provide support in any way possible. Thank you. Those are my closing remarks.
Thank you so much, guys. Just wonderful to have you on the panel with us today. Very grateful for it. And yeah, thank you so much for your time.